Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to have a very brief look at fetal physiology and the CTG. So we're going to have a very short look at fetal heart rate physiology and the CTG. So it was introduced back in the late 1960s as a measure to try and reduce the rates of cerebral palsy, and it was introduced with no real robust randomized control trials to determine its efficacy and whether that would actually really make a difference or not. So pattern recognition became the main way of interpreting those CTGs rather than understanding the pathophysiology behind the features that people were seeing. And so despite these being introduced in the late 60s, it was really in 1979 when the first proper guideline around interpretation of CTGs came out, and that was the American College of Obstetrics and Gynecology did that. Later, FIGO, which is the Federation of International Gynecologists and Obstetricians, introduced their guideline in 1987, because at that point there were more than 20 international guidelines on how to interpret CTG. And really this lack of understanding of intrapartum hypoxia and lack of real control trials, randomized control trials, led to a lot of panic reactions. So when there were decelerations on the CTG, it led really then to people panicking and going straight for cesarean section. So the section rate increased, but there was no decrease in cerebral palsy or perinatal death rates. So interesting really to add to that is that even there are some back as far as 1971, Beard et al. Described that even significantly abnormal late decelerations or baseline bradycardias, the cord pHs of those babies were often over 7.25. And that pattern recognition that increased the cesarean section rates, really we were acting on false positives. So 60% of those were unnecessary cesarean sections. And at that time, it was thought that if the pH was less than 7.25, that actually there would be a poor outcome. This baby was hypoxic. However, we know now with more current large studies that we know that really the most likely babies to develop severe complications of hypoxia are those whose pHs are less than 7. So what controls the fetal heart rate? Well, it's exactly the same as adults, and it's controlled by the autonomic and somatic elements of the central nervous system. So your autonomic nervous system consists of your parasympathetic and sympathetic nervous system. So your sympathetic is your flight and flight response at increasing that heart rate, and your parasympathetic is your rest and relax, or sometimes known as calm and balm. And that's decreasing the heart rate. And the somatic nervous system really is more around sort of body movements, body musculoskeletal activity. So looking at baseline, so we've got our sympathetic and parasympathetic in constant interaction with each other, either trying to increase or decrease the heart rate. And the agreement that those two systems kind of reach is what gives us our baseline fetal heart rate. And the normal range is somewhere between 110 and 160 beats per minute. There will be factors that may influence that. So if there's maternal infection, if the baby's preterm, there'll be other things. So you have to look at the total picture when you are looking at CTG. But what you're actually looking for is a stable baseline, a baseline that stays more or less consistent. And if we look at this picture, you can see if you draw an imaginary line or get a piece of paper and put it across your CTG where the baseline is most of the time, this will give you your baseline rate. So here you can see that the paper is marked off in 20, so you've got 120, 130, 140, 150, 160, and your 110 would be here. Okay, so you draw an imaginary line, and most of the time this baby's baseline is going to be somewhere around the 125, 130. So looking at variability now, we have still got our sympathetic and parasympathetic that are interacting with each other constantly. However, you've also got this constant fluctuation as one's trying to push the heart rate up and one's trying to push the heart rate down. It's going to create a bandwidth, and this is what gives us our baseline variability. And so that will be between 5 and 25 beats a minute. And again, there are a number of things that can impact on that, and we're not actually going to go into those today. Again, looking at this picture, you can see here, you need to look at least over 2 or 3 minutes to get your lowest point and highest point. This is going to give you your variability. And then accelerations. So accelerations are really under our somatic nervous system. Okay, so our somatic nervous system is responsible for all that voluntary control of our body movements via our skeletal muscles. And so these are responsible for the accelerations we see on the CTG. The somatic nervous system may also be centrally mediated. So if you've got accelerations, it's suggesting that you've got a well-developed central nervous somatic nervous system. So it kind of shows you the integrity of that somatic nervous system. It is a hallmark. Accelerations are hallmarks of healthy, non-hypoxic fetuses. Okay, so and the definition of an acceleration really is an increase of 15 beats or more for more than 15 seconds. And if we look here, we can see this CTG has got a number of accelerations here. So I've just circled one of them, but there's one here, 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 and just as the CTG is going off as well. So decelerations then. So a little bit of background as to why these happen or how they're happening. So within the circulation, we actually have something called stretch receptors, particularly in the carotid sinus and the aortic arch. So in labour, you will often get fetal head and cord compression as labour is progressing, and that can be a perfectly normal part of labour. But what happens is that will increase the peripheral resistance, particularly with that compression of the umbilical artery, and that in turn raises the blood pressure. So the baroreceptors are stimulated. They send impulses to the brain, which then send impulses to the vagus nerve, and that slows the heart rate. So that will be seen on your CTG as a variable deceleration. Generally, they're short-lasting with a contraction and a pretty quick return to baseline. And if we look at this picture here, you can see these, although these are quite deep, they are actually quite short and they do return. And if you were to cover all of those decelerations up, the baseline remains fairly stable, and as does the variability. Right, so chemoreceptors, on the other hand, you'll find these peripherally on the aortic and carotid bodies and in the brain. And they are stimulated by the biochemical composition of the blood. So they actually respond to increased hydrogen ions, increased carbon dioxide, and low partial pressure of oxygen. So in labour, when these chemoreceptors are activated, it causes the parasympathetic nervous system to be stimulated, which will then result in a fetal heart rate deceleration, which you'll see on the CTG. They are slower to recover to the baseline rate, and this is because we need the oxygenated blood to reach the maternal venous sinuses to get rid of those things that are actually stimulating the parasympathetic nervous system. So often these types of chemoreceptor decelerations are associated with metabolic acidosis. So you can see here they're decelerating, but they're much, much slower to actually go back to the baseline. So we're going to just take a little step back and have a look at some of the protective measures that the baby actually has to help it cope with labour. So unlike adults, fetuses are not exposed to atmospheric oxygen. When an adult's exposed to hypoxia, we will increase our breathing rate and depth to actually enhance our oxygen uptake. Babies can't do that. So the only thing they can do is actually drop their heart rate in order to reduce the myocardial workload and to maintain its positive energy balance. So this is a reflex response to protect the myocardium against both hypoxic and mechanical stress. And so we're hearing that as a deceleration. So really, from 12 days to term, the embryo/fetus gets its oxygen and nutrients via good uteroplacental circulation. So anything that's going to interfere with that will put that baby more at risk. So things like IUGR, preeclampsia, anything that is going to interfere with that placental perfusion is going to put that baby at more risk of rapidly developing hypoxia in labour, particularly in labour. So one of the other things, poor use of oxytocin, so you get hyperstimulation, that is going to cause reduced perfusion of the placental bed and therefore put that baby much more at risk of getting hypoxia. The baby lives in a relatively hypoxic environment, and at the beginning of labour, its O2 sats are probably only about 70%, and contractions will take them down to as much as 30%. But the baby is an amazing thing, really. Its fetal HB has a much higher affinity for oxygen, so that means that oxygen will bind at higher partial pressures and release rapidly at low oxygen tensions, so that the oxygen can get to those central organs really quickly. Fetal hemoglobin also acts as a buffer against metabolic acidosis, so that helps avoid sort of neurological damage. The other things we've got are our cardiac differences in utero. So you've got your ductus venosus and your foramen ovale, which shunt blood, the oxygenated blood, directly to the heart and brain from the umbilical vein. And you've got your ductus arteriosus, which diverts blood from the pulmonary artery to the descending aorta, so therefore bypassing the lungs completely. And our fetal myocardium beats at a much higher rate. So as we've said, the normal rate would be 110 to 160. So I'm not going to go into all the different types of hypoxia in this particular video. I'm just going to take you through the steps that will happen if we don't remedy, if we put no remedial action in at each point, where this will actually end up on the CTG. So initially we've said in order to protect the myocardium, the fetus will slow that heart rate down. So we will see decelerations on our CTG. If no remedial action is taken to rectify the situation. So, for example, it might be that we've got oxytocin going and she's hyperstimulating, and so she's getting a lot of these decelerations. If we rectify that, the CTG should normalise. If nothing changes in the situation, the next thing that will happen is the baby will try to conserve energy. So it will do that by stopping its movements or reducing its movements. And we've already said the somatic nervous system is the one that is controlling the skeletal muscles. So the baby will reduce its movements, and that will be seen on the CTG as a lack of accelerations. Remember, we said accelerations are usually associated with fetal movement, but they are a really healthy sign. So we will see a lack of those accelerations. If no remedial action is taken, the baby will try to compensate to rectify the situation and try and mobilize its resources. So you will get catecholamine secretion. So you have got decelerations, then a loss of accelerations, then the catecholamine secreted, which will cause your peripheral vasoconstriction to push the blood towards the key organs, and also push the heart rate up. So this will in turn lead to an increase in baseline rate, because the baby is trying to redistribute the blood to the vital organs, as well as trying to get some fresh oxygenated blood from the placenta. So if this compensation mechanism fails, it's not really working for the baby, then it will start to decompensate. And so we're getting a decrease in perfusion to the fetal brain. So we're not getting that oxygenated blood up to the fetal brain. And this will be seen on the CTG as a loss of variability. If nothing happens at that point, then it is the step ladder pattern. You will get bradycardias, eventually leading to death. Things that you can do when you're looking after somebody in labour, if you have a CTG on, then it's good practice really to have what's called fresh eyes at least every hour. And that's, as it says, it should be a second midwife coming in, and you don't tell her what you think the CTG is, the features of the CTG are. It is about her or him looking at it with a fresh pair of eyes. You can become quite blinkered, and when you're looking after somebody, particularly for quite a long time. And if someone says, oh, could you come and do a fresh eyes on my CTG? It's fine, it's normal. I might already be thinking, oh, there's not a problem with that CTG. I may not actually notice because I'm already predisposed to thinking it's a normal CTG. So, as the second person going in to look at that CTG, you should do with an open mind and look at it with your own perspective, not be influenced by anyone who's already been in the room looking at it. It's always useful every couple of hours, I would say, to get a senior midwife to do your fresh eyes. From my point of view, I think as if you were a senior midwife and you're running delivery suite, it's also quite useful for you to know what's going on in different rooms. Not all trusts have central monitoring. So if the core midwife or midwife in charge isn't coming in to see your CTGs, very often she can be unaware of developing patterns. Make sure that you keep abreast of any updates that are coming. And most importantly, when you are interpreting a CTG, you do need to look at the entire clinical picture. Are there any things that put this baby more at risk of developing hypoxia in labour? Is it a preterm baby? Is it a small baby? Is it growth restricted? Is the mother a smoker? Has she got PET? There are a huge number of things that actually could predispose this baby to becoming hypoxic in labour. And there you have it, a bit of a whistle-stop tour through fetal physiology and the CTG. I hope you found it useful, and I hope it helps you with your interpretation going forward of CTGs. If you haven't subscribed to the channel already, please do so, and I look forward to seeing you next time.